Angels leading fox out of the darkness. I find it to me my pleasure to welcome Dr. Praglad Sir, Professor and HOD of Department of Pediatrics, Indira Gandhi Institute of Child Health, Bangalore, with 24 years of expertise in pediatrics, for upcoming case presentation by Dr. Muthumani Ma'am, a final year MD postgraduate ICH.
So with this, sir will proceed with the clinical case presentation. It will be an interactive session, not only for the presenter as well as for the postgraduates. So participate, the time constraint is there, participate equally, and here we are going to concentrate more on the history and examination. Okay, this is what happens in either DNB examination or MD pediatrics or DCH. They concentrate more on how you take the history and how to approach the case by detailed thorough clinical examination. And most of us are worried about the diagnosis. You need not worry about the diagnosis. Your approach is very important. Okay, we'll start.
Master Yogeshwaran, 10-year-old male child, firstborn of non-consanguineous marriage, is brought by mother from Velachery with the following complaints: headache and fever for the past 20 days and vomiting for past 15 days. History of presenting illness: history of headache for the past 20 days, which has been increased in intensity for the past 10 days. The headache is diffuse with no diurnal and postural variation. It is not associated with any aura or photophobia or phonophobia. The headache is relieved by medications. History of fever for past 20 days, low grade intermittent fever. It is not associated with chills and rigor, and it is relieved by medications. History of vomiting for past 15 days, 3 to 4 episodes of vomiting per day. The vomitus contains undigested food particles. It is non-projectile and non-bilious. It is not blood stain. History of altered behavior noted by mother in the form of irritability, and the child talks irrelevantly at times. There is no history of seizures.
Before this, we'll stop it here. This is analysis of the main chief complaints before going to the negative symptoms, is it not? We have the habit of rearranging the chief complaints. Okay, when you rearrange the chief complaints, it will be easy for you to go ahead. So anybody, can you rearrange this? Yeah. So what comes first?
Fever.
Is it not? So that is an important. First thing you would have elaborated on fever, then the headache, then the altered behavior or vomiting. Okay. So when you start with fever, then we know what is the direction, whether I am dealing with the infectious cause or inflammatory cause or neoplastic. Okay. So first thing will be, otherwise headache means we don't know where. There are several causes of headache. Is it not? Which may or may not be associated with fever. So therefore, tailoring the history, modifying the history. First you start with fever as a chief complaint. Okay, she said about fever. Okay, what is the type of fever? And is it a continuous fever? What is the grade of the fever? Associated symptoms? These are all is to be added. Chetan, what should be added for the fever? Quickly, one mic should be given. Guru Raj, quickly, my candidates only I should ask. The intensity of the fever, is it not? So we wanted to know whether it is a low grade fever or high grade fever. She has rightly said it is a low grade fever, but another important point to be added here may or may not be there, but you should particularly ask whether there is evening rise of temperature, because when there is a low grade fever, the mother may not notice the fever. Only the child may be playing and comes to the evening, they can feel the fever. Temperature will be a evening rise of temperature and associated with any sweating, associated with any rashes, chills or rigor. These are all very important. Okay, suppose if it is associated with the rash, then it will take you to another important etiology. Okay, that's an important of fever. And how about headaches? The second symptom she said is very rightly headache. We didn't get any clue. What is the type of headache? What is the intensity of the headache? And what are the aggravating factor? And what are the relieving factor? When you can tell this, you yourself can tell what
Yes,
is the
sir.
type of
Headache was initially moderate severity. It has been more with very intense for the past 10 days. It is not localized to any part of the head. It is diffuse, and there is no diurnal variation or postural variation, and no aggravating factors. It is usually relieved by taking analgesics.
Okay, good. So the most important thing is when there is a fever and headache, we'll connect this. So fever, headache, and the third symptom here, there is altered behavior and vomiting. So when you look at this, is it I am dealing with a neuro infection, or is it a CNS problem, inflammation, or is it a malignancy? Is it not? So we are trying to localize towards a CNS cause rather than the other systemic cause of headache. Is it not? So if it is a CNS cause of headache, it could be due to three causes. What are those?
Increased intracranial pressures,
Very good.
meningitis,
Very good.
any space occupying lesions.
Yes. So these are the three things, is it not? So one, if it is due to meningeal irritation, is it not? So initially, if there is a headache, there could be an initial meningeal irritation. It will be a diffuse, severe headache, and it increases on bending forward. The child cannot bend the neck, is it not? So it's the older child. So you ask for whether it increases on bending the neck forward. And generally, it may not be relieved with simple analgesic. Whereas if it is a migraine, vomiting can release a headache. Second thing is, when there is a raised ICP, what should be the type of headache? Quickly.
It will be severe, and it will be increase on lying posture.
So one, it should be a severe headache, almost throbbing headache, diffuse headache, and it increases on all condition which increases raised ICP, all coughing increases, or exertion, vomiting, lying down posture. So for reducing raised ICP, we increase the head end, is it not? And the child rise down, and early morning. Initially, if the child goes to bed in the night, there will be a washout of CCO2, whatever, then there is chance of reduction in the ICP. But when they got up in the morning, then there will be increase in the headache. When the child started walking, then there will be reduction in headache. Is it not? So this is an important question. And if it is a tumor, almost called thunder clapping headache, so very severe headache, sudden rise in intracranial pressure, they'll have a severe headache, blurring of the vision, giddiness, or they can have a gait disturbance. So these are the things has to be asked when you ask about the headache. Okay, right. Now third thing is vomiting. So vomiting, she said, it's a non-projectile, non-bilious, non-blastine. Again, it doesn't give any clue for you. Does it give a clue whether it is due to neurological or GI symptom?
It doesn't.
Doesn't give a clue. Typically, if it is due to raised ICP,
It will be projectile.
it will be a projectile vomiting, early morning vomiting, is it not? So that's an important of vomiting here. Third last symptom is important is history of altered behavior in the form of irritability, the child, elder child, irritability and irrelevant talks. In addition, whether there is any speech disturbance, irrelevant talk, and what else you'll ask?
Sleep disturbances.
Pardon?
Sleep disturbances, sir. Sleep disturbances.
Okay, sleep disturbance. So sleep disturbance again, rise ICP, and any altered sensorium, then convulsion. So we'll go, I think negative
Negative
history you're
histories.
going to ask. So these are in brief, she is given the history. Let us go for the other negative
Next.
history.
There is no history of seizures or visual disturbance in the form of blurring of vision or double vision. No history of sleep disturbances. No history of disturbance in perceiving smell or visual disturbance, abnormal position of the eyeball, drooping of eyelids. No history of difficulty in chewing foods. No history of inability to close the eyes or facial asymmetry or drooling of saliva. No history of deviation of angle of mouth. And there is no history in difficulty in hearing. No history in difficulty in swallowing or regurgitation of feeds or change in quality of the voice. No history in difficulty in turning the head from side to side or shrugging the shoulders. No history of deviation of tongue or no history of weakness of the limbs. Mother says that the child complains of generalized malaise and history of neck pain is present. No history of involuntary movements and no history of bowel and bladder disturbances. No history of ear discharge or difficulty in breathing. No history of diarrhea. No history of any trauma in the recent past. No history of skin rashes. No history of joint pain or swelling of joints. No history of traveling to any endemic areas in the recent past. No history of dog bite or recent vaccination.
So that's the negative
present.
history. Okay. So one important clue for you, whenever you give no history, negative history, you yourself has to justify that. So otherwise the examiner, what this doctor is saying, keep on saying no history, no history. So why did you ask for this individual symptoms? So keeping in mind what? She rightly said very important thing is, one, there is no history of involuntary movement. So that should be added for this. And she elaborated on more of cranial nerve involvement. Okay, full cranial nerve involvement and motor system involvement you didn't ask for. Whether there any weakness of the
There is no weakness of
limbs,
limbs.
is it not? Upper limb or lower limb? Okay. Suppose the child has got memory loss, psychiatric symptoms. That also should come. Why did you ask for this?
Autoimmune.
Autoimmune, very
Autoimmune.
good. So, to find out the etiology, she will going to ask now, one by one. One is for the complications of the illness, associated conditions and the etiology. So, for the etiology, she asked, one is recurrent diarrhea. You should say one chronic diarrhea or recurrent diarrhea to know whether there is a comorbid condition, is it
Conditions.
not? So, like most important comorbid condition is HIV infection. So, for that you ask for any
Diarrhea.
persistent diarrhea,
Diarrhea.
then ear discharge. Then important thing is history of trauma. You can elaborate on that. What is the history of trauma? Will tell you. This trauma will give us to this fever and headache.
Leading to head
Or-
injury, fall from height, any history of trauma in the form of fall from height or head injury.
Any head injury which will give us to what? Intracranial hematoma. Does it got fever?
No, sir.
No. So on the other hand, trivial
Fracture
head
of
injuries. Trivial injuries, head injury which can trigger underlying meningitis.
Meningitis.
Typically there could be a rich focus which can be triggered and
will cause
which
release
can
of
cause
the bacilli.
meningitis, is it not? So that history you have to go. Otherwise, a chronic subdural hematoma very rare, which can present like a raised ICP, but may not be a fever. Rightly, she asked about skin rashes, is it not? If it is an acute condition, skin rashes. Why did you ask about skin rashes?
Any viral encephalitis can present with skin rashes, exanthem during the fever. Like
Do you mean Japanese encephalitis?
varicella and other viruses can present with viral exanthems.
Yeah. Generally, if it is a viral, most of them are acute presentation. Not go for more than 2 weeks.
2 weeks.
Is it not? If it is a varicella encephalitis, immediately within a week. Post varicella is different. Recent past history. Another important rickettsial fever. So rickettsial fever can go on for 2 weeks.
2 weeks.
There you can get rashes.
Rashes.
Acute, hyperacute meningococcemia.
Meningoencephalomia.
Okay. So that's why you ask about the rashes. I don't know why did you ask for joint pain and swelling of the joint.
Any autoimmune disorders presenting with joint pain and swelling can present with encephalitis.
Yeah. Anybody else?
SLE.
Apart from headache, only fever is there. Arun?
Yes.
Really brucellosis. Okay, so whenever there is a prolonged fever, then you can consider joint swelling with a rash, brucella. Okay, traveling to endemic areas.
JE encephalitis could be a cerebral malaria also.
Okay, so do you entertain JE encephalitis here? Arun, keep Chetan. Classically, it will be acute presentation. JE. The child will come to the ER. Acute onset of fever, headache, altered sensorium, convulsions, and focal neurological deficit. They will not have rashes. So mark it, JE will not have rashes. Acute onset. Cerebral malaria, said no. Cerebral malaria, how they present?
The altered sensorium.
Definitely, yes. Altered sensorium is the first important presentation. Any child with fever with altered sensorium, with pallor and just palpable spleen until proved otherwise from the endemic area, you see, you look for cerebral malaria. Is it not? So that is a hyperacute presentation. Child will come to the ER with almost like a shock-like presentation also they can. Okay. So this is like a subacute clinical condition. It was started slowly and now the child has developed some neurological symptoms. Is it not? So that's why we are thinking in terms of either subacute condition rather than the other viral etiologies. Okay. Right. Yeah. No history of dog bite and recent vaccination. Again, you can entertain that. Dog bite. What will be the presentation?
It will present as encephalitis, sir, with altered sensorium. It can present
altered sensorium is not a feature. Very important.
Hydrophobia.
When you give water,
hydrophobia.
Drink, but because of the spasm, hydrophobia is one of the important hallmark. They will not have persistent fever. They will not have persistent headache. So the most common presentation will be hydrophobia. Is it not? Of course, recent vaccination means again it should happen immediately. There need not be again headache and irritabilities. Okay. So the point what should be mentioned, what not to be mentioned, you have to be very careful. Okay. Right. Anything else? Are you sure? We are in the track. So with this, we are dealing with
some subacute CNS infections,
probably it's a CNS symptom. Okay. Because headache, vomiting and fever, irritability behavior. Means altered CNS involvement. Is it not? Irritability and altered behavior. So probably CNS involvement, we wanted to know the etiology. Okay. Right.
Treatment history. Initially, child was treated in a private hospital in Velachery with oral antibiotics and paracetamol for fever and headache. Child was admitted in ICH 12 days back and child was treated with IV antibiotics. The mother didn't have any improvement in the symptoms such as fever or headache. After 1 week of IV antibiotics, child was started on some oral medications. Mother noticed that the child is passing orange colored urines after starting the oral medications. Now there is the symptoms has reduced in intensity, but there is still persisting symptoms. Past history.
Before that, anything you wanted to add?
During the hospital stay, lumbar puncture has been done and neuroimaging has been done.
That's an important thing. We should not blindly start them on any antibiotics. Some procedure, yes.
Lumbar puncture and neuroimaging has been done.
And based on that, they started on some treatment and the child is passing orange colored urine you are given, so that indicates probably child is having rifampicin. Okay.
Past history.
And the child showing improvement.
Symptoms intensity has reduced, sir, but still fever and headache is there. Mild headache is there still. The child is on oral medications for past 5 days.
5 days. Still headache is there. Suppose the child is started on this treatment, but the condition hyperacutely increases, fever, headache, the child become altered sensorium. So what do you think?
Paradoxical drug reactions.
So that's one of the important
Side
conditions
effect
should
of,
keep in mind. Paradoxical reaction can happen in subacute
But-
meningitis as well as when there is a co-infection with
HIV.
HIV. Is it not?
Past history, no history of any surgeries in the past, no other medical illness
In a younger child, smaller child, another important history you should ask. Majority of the time, this is not the age group what we are discussing for a neuroinfection. The smaller child, usually an infant or a toddler, they will present with this all the symptoms and commonest age group. In that condition, you should ask about any progressive enlargement of the head.
head.
Okay. So majority of the time, suddenly they will present with large head with vomiting, altered sensorium and neurological deficit. That will be an acute presentation.
No history, any surgeries in the past, or no other medical illness in the past. Antenatal period and
Should be
natal period was
specific. No any surgeries in the past.
abdominal and ear surgeries.
Why abdominal surgery?
Sir, any splenectomy can predispose the child to capsulated organism infection, meningococcal and pneumococcal meningitis. Cochlear implant is an risk
Yeah,
factor
but we are
for
not discussing about acute.
Acute.
We are already discussing the subacute or a
Subacute.
chronic condition. Is it? Not?
any other intracranial surgeries like VP shunt can be done in hydrocephalus.
Not a past history, in the present history. So in the present history, especially a smaller child, what we discussed, any tube has been placed. Okay. Any other medical illness in the past? So very important this. What medical illness in the past you like to ask, Meghna? So very important is measles.
Measles.
Then whooping cough, then varicella. So most important, pertussis and measles are definitely trigger the underlying. There could be a reactivation of the underlying tuberculosis, or it can worsen the progression of the tuberculosis. So should specify no other medical illness. One, when there is a measles or any
Varicella, pertussis.
Okay. Third thing is any history of cough. See, the another source we have to find out. Persistent or unremittent cough. Now, National Tuberculosis Elimination Program, they mentioned the
Persistent unremitting cough.
for more than 2 weeks. And in that again, the weight loss. You said generalized malaise.
Malaise.
So, weight loss, progressive weight loss, or
Loss of
not gaining weight.
weight.
Is it not? So, these are the other important symptom you should ask. The persistent, recurrent or remittent cough. That should be added on to the past history. Okay.
Antenatal history was uneven full. Natal history, child was delivered by vaginal delivery, full term. Birth weight was 2.7 kgs, and child cried immediately after birth and was not admitted in NICU for any illness. Child was breastfed within an hour, and postnatal period was otherwise uneven full. Family history, the child is firstborn of non-consanguineous marriage. He has an younger sibling who is healthy. No other family members has similar illness. No other family members has any chronic cough or on any medications.
Okay, similar illness you ask, is it not? Keeping in mind what?
Sir, tuberculosis, any contact or meningococcal infection?
Tuberculosis meningitis will not run in family. Okay. Autoimmune encephalitis. Okay. And important thing
Contact
is the
for
contact. Contact history. So the contact would be the close contact or even the distant contact in the past 2 years. So family history should ask for whether the father or grandfather, mother has got persistent cough or they have taken any
medications,
medications.
chronic medications.
Okay.
Immunization history. The child is immunized up to age as per National Immunization Program. No optional vaccines were given to the child. The child is developmentally normal. He is studying 5th standard with average scholastic performance. No history of contact with known case of tuberculosis.
Okay. Immunization history. What important immunization you like to ask for this child?
So during birth, BCG vaccination. should be asked.
Okay, what is
Then-
the importance of BCG vaccination?
It prevents disseminated TB in 85% of the children, sir, after vaccine.
So severe form of tuberculosis, as well as look at this child. The child is immunized. BCG has been given. Even though BCG is given, child develops some amount of neurotuberculosis, but it will be as milder
Milder
form. So it reduces the severity
Severity
of
of
the
that.
neurotuberculosis also. That's an important of BCG vaccination. Okay.
Socioeconomic history.
Yeah, JE vaccine also you should mention.
It's not
Completion
given.
sake, whenever the neurological case is presented,
So-
optional vaccine.
Socioeconomic history. The child is living in a nuclear family. They are residing in a Pakka house with adequate ventilation. The house has 3 rooms with separate kitchen and toilet facilities. They are using gas for cooking, and the water source is from public tap. According to modified Kupaswamy classification, they belong to lower middle class. Dietary history. The child takes 1750 kilocalories as against 1900 kilocalories with a deficit of 8%, and takes 36 grams of protein as against 40 with a deficit of 10%. Summary. 10-year-old male child presenting with subacute onset of fever, headache and vomiting, which does not improve with IV antibiotics, without seizures or any history suggestive of focal neurological deficit, and no other significant histories.
No, another important symptom you must know, irrelevant talk, irritability,
with
behavioral
altered behavior.
disturbance, and no history of seizures. So no history of seizures, no history of any other weakness of part of the
Limbs.
body or involuntary movements. Fine, and no history of contact. No improvement with this. So what you think of?
Subacute meningoencephalitis, probably without any contact history.
Yeah, but we
Could
don't
be.
know whether we are dealing with
Etiology could not be.
meningoencephalitis after examination. So neuroinfection. So say probably one is neuroinfection, or I'm thinking in
Could
terms
be
of
autoimmune. Also could be
that's
autoimmune
also
encephalitis is also a possibility.
inflammatory response, whether it is autoimmune encephalitis. Third thing is
Uh,
child has got headache and vomiting. Still
Raised SOL, space
SOIL
occupying
is possible.
possibility.
Is it not? So three things I am keeping in mind before examination. So neuroinfection, inflammation, autoimmune encephalitis. Third
And
thing is a space occupying lesion.
lesions.
So these three I am keeping in mind and proceed with the examination.
General examination. The child is examined in supine position. The child is conscious, orient to time, place and person. The child is afebrile. No pallor or cyanosis or clubbing or icterus. No pedal edema or generalized lymphadenopathy. Head to foot examination. Eyes are normal, ears normal, no discharge. Nose and throat normal. Oral cavity, dental caries and after ulcers were present. BCG scar is absent. No surgical scars anywhere else in the body. No external markers of tuberculosis. Limbs and joints normal. IV line is present in the right hand with no tenderness or redness over the IV site. Skin, no rashes or purpuric spots. Spine normal, no deformity.
Okay, anybody head to toe examination, what all to be? She has mentioned most of the requirement. So what you going to examine, head to toe examination. One is we want the etiology, is it not? The etiology. Second thing for the complications of the illness and other comorbid associated conditions. Okay, now three things we have to examine clinically. So anything in the head? Yes, brain. Sir saying. Pratibha? So one is, yeah, she will going to mention in the anthropometry, okay, how the head looks, whether it is looks larger for the size of the body. Then the eyes, very important, look for
Flinctons.
so vitamin deficiency, Flectinular
Conjunctivitis.
conjunctivitis. Okay, jaundice.
Jaundice.
Why jaundice?
Acute necrotizing.
The child
Child
is
is on
already
ATT.
having. One is the child is on ATT.
ATT.
If it is a smaller child given to you, most of the time this baby will not be given to you. The only minimal signs the child has got. Usually between 1 year to 3 years. A toddler age group, commonest age group will be given to you. In that case, if you have jaundice, think of Ranjita. One is drug induced. Before that,
Acute necrotizing and
disseminated tuberculosis. Miliary tuberculosis can involve liver. Okay. So jaundice.
Jaundice.
Eyes you should examine for lectin, vitamin deficiency, jaundice. Then neck, preferably look for
Lymph
any
nodes or
lymph nodes. You specifically say there is no significant lymphadenopathy, no cervical or matted lymph nodes. We are looking for a cold abscess, a sinus. Okay. The ear, look for any perforation, the chronic otorrhea. We want HIV also, you said no, associated HIV. So any otorrhea, whereas tuberculosis can be
the cause of chronic
perforation, no, not false smelling. Okay. Then the skin manifestation. What is the skin manifestation? Tuberculosis.
tuberculosis,
Scrophulosderma.
lupus scrophulosderma, lupus vulgaris, tinea
Yes.
versicolor, subcutaneous tuberculosis, erythema nodosum.
Erythema nodosum. Okay, so if it is, that's an important finding. The tender erythematous nodules,
Nodules.
especially over the extensor aspect of the shin. Look for erythema nodosum. Okay, of course, you are going to see the spine. You said instead of saying normal,
No
look for
deformities.
any
Kyphoscoliosis or
kyphoscoliosis.
gibbous.
Typically mentioned there is no any particular swelling, gibbous, or the spine. Okay. Then the hands. So when we discussed previous case, is it not? The attributed bronchiectasis due to
Nails.
tuberculosis. So if it is a disseminated tuberculosis, you can see clubbing.
Clubbing.
Okay, so clubbing also you can mention. If it is a smaller child, not in this child, active child, and this child will not have a underlying problem. Especially I am telling about the smaller child. Okay, so these are the things you should look for. Of course, a younger child, signs of malnutrition we already discussed. Look for the signs of malnutrition. And BCG scar
Absence.
absent. So why BCG scar is absent?
Sometimes inadvertent injection of subcutaneous BCG at subcutaneous level may not cause scar.
So yesterday we discussed already, when there is no scar, the child comes to you within 1 year, you wanted to repeat BCG or not?
Need not
All of you say no,
No.
no need to
repeat.
BCG. Okay, right. Sometimes a younger child, again BCG adenitis.
Adenitis.
Look for axillary BCG adenitis. And head to toe, mainly they will ask you to palpate the neck. Look for
Lymphadenopathy.
any
Shunt.
reservoir. Okay, it will be missed many of the time. The younger child undergone surgery, the BP shunt will be there. You will be missing the shunt, and you should know how to test for whether it is functioning or
Patent.
not. Okay, right.
Anthropometry, the weight of the child is 27 kgs, which is under 10th to 50th percentile, height 141 centimeters, 50th to 90th percentile, BMI is 13.5, it falls under 3rd to 10th percentile, is normal for age. Vitals, heart rate 92 per minute, respiratory rate 18 per minute, thoracoabdominal type of respiration, BP 100/80 in a right upper limb in sitting posture, temperature is 98.5 degree Fahrenheit.
So impression normal.
Normal.
So here the vitals should be given importance. Again, not in the child, stable child, and the child comes to you with alter sensorium. Okay, GCS is 6, and the child will have a
Posturing.
Okay, in that case, look for what is Cushing's
Triad.
triad. What
Bradycardia,
is that?
bradycardia, hypertension, and irregular respiration.
Yeah, systolic hypertension,
Mention.
irregular respiration. These to be given importance. So, what are the types of respiration you look for? Muthamani,
Chinese stroke breathing, which is a period of
Because
hyperpnea followed by bradypnea
so whenever
alternatively.
there is a CNS case is there, you should above downwards. So it gives a clue for the prognosis. First thing will be
Chinese stroke breathing,
cortical hyperventilation, is it not? Then
Chinese stroke breathing,
chain stroke breathing. What is chain stroke breathing?
a period of hyperpnea followed by bradypnea alternatively with a pause in between.
So third is go down. So you are gone cortex,
Bradypnea.
then midbrain you completed, then pons. What will be if it is a pons? What type of breathing? Dibharti, right? Apneustic breathing. What is apneustic breathing?
Uh,
Deep, irregular breathing in between pass.
Pass.
Okay, that's also very and gasping type. It's an irregular breathing. Pons we completed. Next we go to medulla. The dangerous. What is called as Pratibha? Good, yeah. Ranjita? Sujata? Chetan? Biot's breathing.
bios.
So bias breathing is it's a quick shallow irregular breathing with apnea. So that's an end stage. The apneustic and bias breathing, it's almost child is brainstem involved. So child is going to die if you don't intervene immediately. So this is a clue for various types of some examiner will ask you when there is a raised ICP, what are the signs of respiration you are going to see. Okay. So that's an importance of vitals.
Systemic examination, CNS system, higher mental function, the child is conscious, oriented to time, place and person, the child is right-handed, memory, speech and sleep normal, mood and behavior, the child is irritable on examination. Cranial nerves, first cranial nerve, the child is able to perceive smell, second cranial nerve, visual acuity is 6/6, visual field is normal, tested by confrontation method, color vision is normal, pupillary reflex is present, fundus is normal. Third, fourth and sixth cranial nerves, extraocular movements are full in all direction, no squint, no ptosis, direct and indirect pupillary reflex is present, accommodation reflex is present. Fifth nerve, sensations over the face is normal, muscles of mastication is normal, corneal and conjunctival reflex is present. Seventh nerve, wrinkling of forehead present, the child is able to close the eyes, nasolabial fold present on both sides, able to hold air in the mouth, taste sensations in the anterior two-thirds of the tongue normal. Eighth nerve, Rennie's test, air conduction is more than bone conduction. Weber's test, sound is equally heard on both sides. Ninth and 10th cranial nerve, gag reflex is present, uvula is in the midline, palatal movements equal, no nasal twang in the voice, the child is able to swallow the food. 11th cranial nerve, able to shrug the shoulders and able to turn face from side to side. 12th cranial nerve, no deviation of tongue, no fasciculations are wasting.
So cranial nerves, she said almost most of the cranial nerves are normal. So most common cranial nerves affected if you think of tubercular meningitis.
3, 6 and 7.
Second also.
Second.
Okay. 3, 6, 7 and second cranial nerve. So these are the cranial nerves you have to give importance. Second cranial nerve, she said fundus is normal. So what you are looking for in second cranial nerve? Fundus. In this child, especially
Choroid
smaller
tubercles.
child given to you. Okay. So one, you look for papilledema.
Papilledema.
When
For
there is a papilledema. Second thing, choroid
choroid
tubercles. Third thing, look for optic atrophy. So these are the things as a sequelae they can develop. Initially papilledema, then optic atrophy. Then the pupils, very important. So you should mention, even though it is normal, what you are looking for, whether it is an unusual pupil. See, I am not telling about in this child. Suppose that the child comes to you with severe altered sensorium, posturing, then we have to see whether there is associated brainstem involvement. The pupils, look for unequal pupils. It can be totally constricted. What you call that condition?
Pinpoint pupil.
Yes.
Present in pontine hemorrhage.
No,
and
in these children.
in this children,
Suppose you think of tumor, we will discuss, is it not?
pontine tumors.
Harness syndrome. What you'll have? Yesterday, there's a photographs note.
Meiosis.
Constricted and drooping of the eyelids.
Ptosis.
Can be there. Then it could be unuchal, that is dilated pupil one side.
It's a sign of.
It can happen in opticotropy, bilateral dilatation, but if it is unilateral dilatation with irregular respiration, Guru?
Due to herniation of brainstem.
Yes,
Herniation of brainstem.
very dangerous condition. The child is going to have herniation. We should intervene immediately. Look for any herniation. So fixed dilated people. Another important thing is almost like brain death, is it not? And if with a smaller child, the third, fourth and sixth can be tested by smaller child, unconscious child.
Dalsay movement.
What do you mean by Dalsay maneuver?
Sir, after lifting the eyelids, if we turn the head to side, the eyeballs moves in the opposite direction of the movement of the head. Means the Dalsay is intact. The brainstem is not affected.
So we are testing one of the important brainstem reflex. In this child is difficult in the conscious child. In an unconscious child, you should either vertical or horizontal. So horizontally, if you turn the child to the left, the eyes together which will move to the opposite side. Again, turning to the opposite side, it will move to the opposite side. So conjugate deviation is there or not, you have to say. Similarly, gaze palsy. What do you mean by gaze palsy? You have to look for any gaze palsy in the children. What is gaze palsy? Either upward gaze palsy or downward gaze palsy. The downward gaze palsy or upward gaze palsy, which is dangerous? Which is dangerous?
Downward gaze.
Downward gaze palsy. Which condition you will get?
Superior, fourth cranial nerve. Fourth cranial nerve involvements. Superior oblique.
Typically in Bell's phenomenon, is it not? The child tries to look up and it cannot. Facial nerve nucleus. Whereas this down, the upward gaze palsy, where you try to look up but the child cannot. It is an important tonsillar herniation. Okay, the downward gaze palsy. So look for conjugate deviation of the eyes, gaze palsy, then Dalsay maneuver. These are all has to be done typically when the smaller child is given. And many syndromes can be associated with tubercular meningoencephalitis. Suppose third nurse palsy with ipsilateral hemiplegia. What do you call that condition, Bhargavi?
Weber's.
Very
Weber's
good.
syndrome.
Weber's syndrome. So some of the syndromes you should remember. Seventh nerve palsy, sixth nerve palsy with ipsilateral or contralateral hemiplegia.
Miller-Huber.
Miller-Gubler, seventh and sixth. Sixth isolated. Riemann syndromes. Okay, like this, some of the syndromes, Perrinot syndromes can be associated. So these are the examiner will expect when you are examining the CNS examination and the child is having a neurological deficit. Okay, so most common cranial nerve which are involved, what I am going to look for in these children. Okay.
Motor system, bulk is equal on both sides. Tone is normal on all four limbs. Power is 5/5 in all joints. Finger and toe grip is good. Deep tendon reflexes. Biceps and triceps are present in both sides. Supinator is brisk on both sides. Knee and ankle jerk were exaggerated during the time of examination. Superficial reflexes. Abdominal reflex is present. Cremastic reflex present. Plantar reflex is withdrawal on both sides. Sensory system is
Plantar, you say withdrawal or so three things you can say in this baby. Younger child say withdrawal. The older children, whether it's a plantar flexor, extensor, or equivocal. So what happened here?
So child withdraw the leg for the stimulus, sir.
That means your stimulus is strong. So gentle stimuli look for any plantar flexion. So with this exaggerated reflex, if there is a plantar extension, then you should think of
Upper motor neuron lesion.
yes, pyramidal tract involvement. So whenever there is a brisk reflex, you forgot to mention
Clonus.
clonus. Always when there is an ankle jerk is exaggerated, look for
Clonus.
ankle clonus. They will ask you to demonstrate ankle clonus. Okay.
Clonus was not present.
Not present.
Sensory system was normal, no cerebellar signs, no involuntary movements, gait was normal, spine and cranium normal, signs of meningeal irritations were present, sir. Neck stiffness, a Kernig sign, Bretzinski's sign was present.
So most important thing is she says the signs of meningeal irritation. So signs of meningeal irritation including she said Kernig sign, Brudzinski sign as well as neck stiffness is present. That indicates there is definitely child has got meningeal involvement. Okay. The other thing is the head, anything spine is normal, cranium normal. What you should mention?
Any
Head. Look for Arun. What you look for in the head? Ma'am is giving a clue. Thank you, ma'am. Is it not? Yeah, McEwen sign. See, many of the time the child may have what you call arrested hydrocephalus, so which cannot be manifested. So you should lift the. How do you look for arrested? The McEwen sign. Make the child to lie down and lift the head and percuss horizontally along the line of sutures and look for the here for the crackpot sign. Okay, so typically you should look for the crackpot sign, sutural separation, and the spine look for the
gibbous.
Is it not? And another important thing is even though he looks normal, you have to make the child to walk and see. Gait you have to check for, is it not? The gait is important. Suppose the child is swaying to one side, that's a very important clue because differential diagnosis we thought of tumors also. So when there is an ataxia, cerebellar ataxia, the swaying to one side, even the medulloblastoma, astrocytoma can be missed. Okay, so look for the gait and sensory disturbance you said. Okay, suppose the child has got a reduced tone, decreased reflexes. So what you can consider in this child? Majority of the time they can have this presentation, smaller child. Chetan, what do you think? What do you think? It's including upper motor neuron, is it not?
Spinal cord involvement. Spinal cord tuberculoma causing compression of spine.
No. That will cause paraplegia. Part spine, paraplegia. But here the child has got CNS involvement and the lower motor neuron signs. What do you call? Two things, either spinal arachnoiditis or myeloradiculopathy. So this can be a common presentation of tubercular meningitis. So you wonder the child is having upper motor neuron signs, but you are not able to elicit the reflex, and there will be decreased tone. So in that condition, so there is an association. It involves the spinal meninges also. They can have then the radiculopathy, the tracts also can be involved. Sometimes like GBS like presentation. So these are the rarer presentation of these conditions. Okay.
With this other system examination, respiratory system, normal vesicular breath sounds heard equally on both sides, no added sounds. Cardiovascular system, first and second heart sounds heard normally, no murmur. Abdomen soft, no organomegaly, no tenderness. A bowel sound was heard.
So all the systems are very important. We thought of a smaller child, if it is a disseminated tuberculosis, the respiratory system, we look for crepitations,
Crepitations.
okay, and pleural effusion
Effusion.
can be there, and in the older children, cavitation. So these are the things to be examined, the type of respiration, and if it is a cardiovascular system, unusual, very rarely, what they can have.
Pericardial effusion.
Pericardial effusion, good. And the abdomen, abdomen most
hepatosplenomegaly.
important. Many times,
Hepatosplenomegaly.
hepatosplenomegaly, doughy feeling of the
Of
abdomen
abdomen.
has to be looked for. And the abdomen, so one important other thing she couldn't mention in CNS examination, Shivaranjani,
Abdominal reflex. I have mentioned abdominal reflex, sir.
autonomic disturbance.
Disturbance.
Okay. So one of the most important, when I was a postgraduate, my teacher used to describe, you look for this tachycerebral. Okay. That is stroking the perabdomen. So there will be formation of wheel and
Wheel.
flare. So indicates severe autonomous disturbance. On those days we didn't have other tests. They said it could be equivalent to tubercular encephalitis, but that is not true. But you should look for the autonomic disturbance, mainly tachycerebral. Okay, right?
With this.
Just 2 minutes. Okay.
Case of subacute meningoencephalitis without any neurological deficit or other complications like hydrocephalus, probably due to tuberculous meningitis or partially treated pyogenic meningitis. Etiology has to be investigated.
So etiology now, this condition is tubercular meningitis. The condition, if it is a smaller child, you look for decerebrate and decorticate posturing on examination. If it is a decerebrate, indicates very bad prognosis. Decorticate, again, staging is important. And if it is not, tubercular meningitis is a diffuse involvement. We cannot pinpoint, localize the lesion unless it is a tuberculoma. So anatomical localization is difficult in tubercular meningoencephalitis. Okay. And if it is only tuberculoma, then you can localize, see where exactly it is. They can have a focal neurological deficit. So your diagnosis, child has got meningeal signs without any other symptoms of raised ICP and recovery phase, and probably meningitis
due to tuberculosis. Tuberculous
due
meningitis.
to tuberculosis, because what is the reason?
Meningitis causing arachnoiditis.
We don't have any other clue for a tubercular meningitis here. Only thing is, it's a mild grade fever. Is it not? And prolonged
Subacute
fever,
presentation.
headache and vomiting, alter behavior, and no history of contact. So majority, nearly 50%, you may not get history of contact. Okay. So that's one of the common condition in our country, which can have a chronic meningitis like picture. That's why I'm thinking of tubercular meningitis. And staging is important. What is the stage here?
Here it is stage 1. 1, 2.
No, see,
2.
You are done very well, Mani. Yeah.
Stage 2. Stage 2.
Yeah. So initially, stage 1 will have just whatever the prodromal phase. Once it presents with meningitis, then you call it as
stage 2.
Stage 2, when there is a rupture of the ridge focus and enters the subarachnoid space, it causes all signs of meningeal irritation. When there is a signs of meningeal irritation,
it is stage
called
2.
Stage 2. Stage 3
is a progressive version of vital and with the decorticate
and
decerebrate posturing, seizures.
Yes, seizures can be there in stage 2 also. So you should be clear cut. This is important for prognostic point of view. Okay. So probably stage 2 meningoencephalitis, tuberculosis. Don't bring here partially treated pyomeningitis, because different entity. Initially they'll have high grade fever, then they'll start antibiotic, then the child is not showing improvement. So we should not bring it here. Okay. Autoimmune encephalitis, can you bring it here?
Yes. Could be a possibility.
Could be a
Sir.
possibility, but we don't have the most important neuropsychiatric manifestation, which is not there in the cell. Seizure is not there, so unlikely to be autoimmune encephalitis. Can you bring out a tumor? You said tumor.
Uh, Fever, prolonged fever.
Can be there.
Can be there.
Fever, headache, vomiting is there, but you started with some treatment, child is showing improvement. So unlikely to be a tumor. Okay, so these are the things, and the best criteria to diagnose TBM will be right now
Lancet's criteria.
modified Ahuja's criteria. So you can have modified Ahuja's criteria for diagnosis of tubercular meningoencephalitis. It has history, examination finding, extrapulmonary association, CSF finding, as well as the CT changes.
Findings.
So they will ask you what is the CSF changes in tubercular meningitis. Okay, what are the classical CSF changes, and when you obtain the CSF, what you look for macroscopically?
Cobweb formation.
Whether it's a straw colored opalescent fluid, look for
cobweb formation.
Is it not? And measure the classical TB will have lymphocyte predominant protein raised and
low
reduced
glucose.
Chloride will be reduced. ADA may or may not be
raised.
The most important test to diagnose CSF is, as on today, tubercular meningitis, CBNAT. Now right now will be good for CBNAT. And if given a choice, will you do a CT or MRI?
MRI with the contrast enhancement. Basal meningeal enhancements will be better in MRI. And
CT scan initially can miss. So it can be normal in 30 to 40% of the children. Early manifestation can be missed. So that's the reason MRI and MR spectro. MR spectro, what you look?
In tuberculoma, there may be lipid peak. Lipid peak will be there in MRS, sir. Yes. MR spectroscopy.
Okay, so these are the things they will ask you in the exam to completion sake. Of course, National Tuberculosis Elimination Program. So you should be thorough, Nikshay, those things should be 10 marks essay question will be there. And what are the complications of TBM? Most important complications?
Hydrocephalus.
So whenever you ask complications during the stage of the illness and the sequelae, you should divide into two groups. So during the stage of the illness,
cranial
the most
paralysis.
important complication is SAADH.
SAADH.
Okay, you should look for SAADH because it's a treatable condition. SAADH. Then of course seizures.
Focal neurological deficits, cranial nerve involvement.
And the hydrocephalus is communicating or non-communicating?
Communicating.
So common again is a communicating hydrocephalus. Mechanism of hydrocephalus, indication for surgery, and what is the shunt you use? What is the shunt you will use to reduce the hydrocephalus? What is the VP shunt? Good, yeah. So there are three types: low pressure, high pressure, medium pressure. So medium pressure is Chapra shunt, what we are using. Okay, and the complications of shunt. Okay,
infection and
infection,
failure.
migration, those things they will ask you. So these are the things can be asked. Lastly, what is the prognosticating point? What are the bad prognostic markers of TBM?
Sir, late stage of presentation, late initiation of the
First
treatment.
is age of presentation. Younger the age, less than 1 year, bad prognosis. Associated SAM, malnutrition.
Associated with HIV infection or other comorbidities.
That's an important thing. Stage 3.
Presentation at a later stage is a bad prognosis. Delayed initiation of treatment is a bad prognostic factor.
So these are the important, and miliary tuberculosis. When there is a miliary, that's also an important bad prognosis signs. Okay. Any questions?